So now can we please proceed with our next session, which is on pancreas, and our respected chairpersons are Dr. Hirdaya H. Nag, Dr. Raghavendra Rao, Dr. Monika Gupta, and Dr. Sudip Naidu. I repeat, Dr. Hirdaya H. Nag, Dr. Raghavendra Rao, Dr. Monika Gupta, and Dr. Sudip Naidu. Okay.
Good afternoon. First presenter post-lunch session is Dr. Isabella Fregerio. He will be talking on conservative surgery. She will be talking on conservative surgery for PNET, the evidence and the practice. Sorry, Dr. Isabella. Wrong.
Much, Chairman and dear colleagues. First of all, I want to tell you it's really a pleasure and an honor for me to be here today. It's the first time for me in India, so I really want to thank the president of the conference, Dr. Rajneesh Singh, and Dr. Sanjoy Madal, and Dr. Yogesh Vajist for their kind support and their invitation. My talk will be about conservative treatment, conservative surgeries for pancreatic NET, the evidence and the practice. I have no disclosure. Pancreatic neuroendocrine tumors are a rare disease. They occur in 1 up to 2% of general population, and they represent 2% of all pancreatic tumors. But despite all, they are the second most frequent indication for surgery, knowing that the main indication for surgery is pancreatic ductal adenocarcinoma. Due to the improving of technology of traditional imaging, we are assisting to a really increasing number of incidental diagnoses, mainly on young and healthy asymptomatic patients. Among them, we can say that up to 90% of surgical resection are considered curative, and this is in the case of localized pancreatic NET. And this happens because almost the totality of them, up to 95% of resected pancreatic NETs, are G1 and G2 tumors. That means well-differentiated tumors. But despite these very good results, we have to remember that up to 10% of pancreatic neuroendocrine tumors, even the smaller one, hold a malignant potential with a risk of recurrency and a risk of nodal and distant metastasis. We do have now different tools to have prognostic factors by considering tumor size, WHO grading system, the number and the presence of nodal involvement, the R status, and the presence of perineural and perivascular infiltration at pathology. But we should remember that we are talking about a different tumor than adenocarcinoma. These patients have anyway a good, if not excellent, long-term prognosis. And this is a real relevant factor that we should think of when we are thinking about the best surgical strategy to treat them, because these patients have a long lifetime expectancy. And this is more or less the principal rationale of my talk. We are trying here to treat symptoms to solve a disease which is usually a benign or low malignant disease, trying to preserve our patients from developing new onset of diabetes and trying to preserve them from long-term complications related to diabetes, preserve them from exocrine impairment, that means having medication daily for your lifetime, that in one word means preserving the quality of life. But at the same time, we need to offer them the best surgical and oncological outcome that it's possible to offer them. He is not a surgeon, he's a German architect, Van der Rohe, and but I really like the concept beneath his style. And his concept is that less sometimes is more. And I think this can really perfectly apply to what we are talking today. Less surgery may provide to our patient a bigger benefit in terms of quality of life and long-term follow-up. Talking about parenchyma sparing surgery in pancreatic NETs, we are talking about essentially two kinds of operation. Tumor enucleation, and you can see here a very well-defined insulinoma of the body of the pancreas. Is usually performed for single lesions when a safety distance from the main pancreatic duct is maintained. And of course, it preserves 100% the pancreatic function, and it's easily feasible with minimally invasive technique. The other kind of surgical resection considered in the atypical resection is the middle pancreatectomy that was first described in 1982, actually in Italy. It's indicated for benign or low-grade malignancy lesion. It gives the possibility to have a residual tumor that protects the patients from long-term functional impairment. And it's usually considered when enucleation is technically not feasible. And it's a rare indication for a rare disease, as I said before, because it accounts for less than 5% of all resections in high-volume centers. But first of all, can we offer our patients this treatment? Are these kind of surgeries safe enough for them? And I'll show you results from a few studies from the recent literature. They are all retrospective series. This is probably the most, the one with the highest number of patients, 820 patients, retrospective series from 4 high-volume centers. The main aim of the study was looking at long-term follow-up, so oncological follow-up. But they, of course, they looked even at the short-term postoperative morbidity. They saw that central pancreatectomy, more than enucleation, had a higher rate of general complication, more severe complication, more severe grade of pancreatic fistula, higher rate of postoperative hemorrhage, and higher rate of operation. And here another study, always a retrospective series, 210 patients, multicentric again, focused mainly on small endocrine tumor of the pancreas. And this is important because you will consider atypical resection and parenchyma sparing resection mainly for smaller lesions, for smaller tumors. And here again, they found that these patients undergone to atypical resection, they had a higher rate of pancreatic fistula. But this higher rate of complication did not impact the overall severity of complications at the 30 days mortality. Another study from a retrospective series with less patients, only 73 patients. And this is the only study, probably this is due to the lower number, the only study that does not find any significant difference in the postoperative outcome of standard surgery and parenchyma sparing resection for pancreatic neuroendocrine tumors. But at the end, the truth comes from meta-analysis. And we have this meta-analysis analyzing 24 studies for a total of almost 1,700 patients, comparing traditional surgery with parenchyma sparing surgery. And these results confirm the fact that the parenchyma sparing surgery in terms of central pancreatectomy have a higher rate of overall general complication, a higher rate of postoperative hemorrhage, a higher rate of clinical relevant pancreatic fistula, and of course a higher rate of hospital staying. But these patients survive the operation. They don't have a higher rate of mortality compared to traditional surgery. So are we justified to offer this higher risky surgery? I think yes, because this surgery will preserve them from long-term complications. As you see, they develop a lower incidence of new diabetes, and they develop a lower incidence of exocrine insufficiency. And this is directly due to the fact that we preserve a higher volume of pancreatic gland. And again, these results are confirmed by this meta-analysis, both about endocrine and exocrine insufficiency, in favor of parenchyma-sparing resection. So, is this higher risk of postoperative complication justified by a benefit in the long-term oncological follow-up? We'll see in a second. I focus mainly only on study that analyze results from small pancreatic neuroendocrine tumors, because as I said before, these are the cases where I would consider to offer parenchyma-spare resection. And what they see, this is the series from the Annals of Surgery, the 820 patients. It's a retrospective series, and I think that this is mainly the main bias for the study, because the surgeon probably decided to offer a traditional resection to the patient that in the preoperative setting somehow seemed to be more suspicious to have a more aggressive disease. And what they found in the retrospective analysis of this patient was the patients who undergone oncological resection had a higher poor degree differentiation of the tumor, a higher vascular and perineural invasion, and a higher number of harvested nodes and positive nodes. But the parenchyma-sparing patients had a higher rate of R1 status, which is easily understandable if you think about the fact that you are doing a limited resection for a potential malignant tumor. But the interesting thing is that both this group of patients, they did not find any difference either in disease-free survival or in median overall survival rate. That means that regardless the nodes, regardless the positivity of margins, this disease has really a burden of low malignancy. And again, the series from the 73 patients, retrospective series monocentric, they did not find any difference both in the recurrence rate and in disease-specific survival, comparing traditional resection to parenchyma-sparing resection. The only factor that made a real significant difference was the tumor size and the presence of a well or poor differentiated tumor. But this difference was confirmed only in disease-free survival and was not confirmed in the overall survival of these patients. So you were asking to me about the evidence of data regarding parenchyma-sparing resection for pancreatic NETs. I am very sorry because the evidence of these studies lies in the middle of the pyramid of the scientific evidence, even if we do have a meta-analysis, because that meta-analysis is based mainly on retrospective studies. So its value is not on the top level of the scientific evidence. And what about the practice? I showed the picture that I showed you before. It was a female with a functioning selenoma, of course, of the body. We treated her after being sure that it was a single nodule with the endoscopic ultrasound. We treated her with a preoperative stenting in the pancreatic duct so we could perform safely a minimally invasive insulinoma enucleation. And this is another case, very similar, but it's not the same. As you can see, it's always a female. She had a cystic neuroendocrine tumor. The diagnosis was confirmed by endoscopic ultrasound. But as you can see, the lesion was completely intrapancreatic, so enucleation could not be proposed. And we performed a middle pancreatectomy. And now here I have a short video. You can easily see the limit between the healthy pancreas and the lesion arising to the margin. This lady had two or three episodes of mild acute pancreatitis before diagnosis. And this was probably the main tricky part of surgery, because technically it was really clean surgery, I would define it. But you see on the superior margin of the pancreas, that's the portal vein and the splenic vein, on the inferior margin. On the superior margin of the pancreas, we had some adhesion due to the previous inflammatory episodes between the hepatic artery and the origin of the splenic artery that should be preserved, of course. here preparing the superior margin and the portomesenteric space behind the pancreas. I don't operate so fast as the movie goes quickly. So this is, we usually put 2 stitches with hemostatic purpose before cutting the pancreas. We use a mechanical stapler. And here we prepare the distal stump along the splenic vessels. The section is done, as you see, with the blade, and we get ready for pancreatic anastomosis. As you see, the pancreas is very, very bad. That means very soft with a small pancreatic duct. Some technical tips about management of pancreatic stumps after pancreatic middle resection. What do we do usually if the thickness is not exceeding 2 centimeters? We use a stapler we do a stapler section, leaving the cold section only for the thicker pancreas. You can choose to do a selective suturing of the Wirsung or to do a thermal section with radiofrequency or any other energy device, but there is no study demonstrating that one way is superior to another to preserve the patients from pancreatic fistula. And as I showed you before about the R status of the margin, for us is mandatory, if I do a parenchyma sparing resection, to have a frozen section of both margins during operation. Because if I choose this surgical strategy, I have to be sure that I'm offering a surgical complete treatment to my patient. We used to have ultrasound during operation as well to see if there is any undetected lesion in the pancreas, to check the closeness to the Wirsung. It might change our strategy, and to define the exact in vivo location of the tumor. And this might change our strategy as well. And what about the distal stump management? We usually do a pancreatic jejunum anastomosis, always putting an external pancreatic stent if the fistula risk score is above 7. But you can it depends on the habits of your center. You can also do pancreogastro or duct occlusion if you want. Our practice in the place where I work, this is the Pedersoli Hospital in Peschiera del Garda, close to Verona in Italy. Our experience accounts for 1,000, almost 800 resections in the last 10 years. And to give you the idea of how rare is the indication of a parenchyma sparing pancreatic resection, this accounts for 2.8% of all pancreatic resections we do. And among histology, 11% of all the resected patients had a neuroendocrine pancreatic tumors. And if we look at these 11% of patients, only 12% of them receive a parenchyma sparing pancreatic resection. That accounts for 1.3% of all pancreatic resection that we do. And here's some data about these patients. Only 9% of that is 22 patients, so it's a very, very low number. That's why it will be so difficult to do prospective studies to validate these results we have seen from retrospective studies. Only a few of them, 9%, had preoperative diabetes. Half of them, 55%, were symptomatics, and 1/3 of them had a functioning tumor. Tumor size was very, very low, 15 millimeters. We performed mainly by minimally invasive surgery, and the overall morbidity was 69%, accounting most of them for pancreatic fistula. We did not have any grade C pancreatic fistula, no mortality, and no reoperation. And what about oncological result? 86% of them had a well-differentiated tumor with 100% of R0 resection. 9% of nodal involvement, and they are all alive without disease after 65 months of follow-up. My conclusion is that parenchyma sparing resections for pancreatic neuroendocrine tumors are feasible and safe. But it remains a rare indication for a rare tumor. That means that it should be tailored on a single patient. Even small-sized tumors may hold a potential malignancy, so we should be able to know the prognostic preoperative factors to address this patient to the best surgical treatment. And intra and postoperative management should be carried on high-value center as well as the correct follow-up. For who of you wants to ever come to Verona to visit the city or to visit the place where I work, which is in Garda Lake? This is not the hospital, but it's just the nicest spot in Garda Lake. You are very welcome. With me and my team, we will be happy to welcome you. And I thank you again for the wonderful hospitality I had here in Kolkata. Thank you very much.
Thanks, Dr. Isabella. Congratulations for an excellent presentation. Open for discussion now. Any question from the house? We'll take up first.
Isabella, thank you very much for this wonderful overview. I have a question. As you said, the G3 tumors or the carcinomas had a poor prognosis. So this is key to know preoperatively if you have these kind of tumors. Then I think a perihumor sparing operation is not allowed then. So how do you manage this in the preoperative workup?
We try, usually poor differentiated tumors are the biggest ones, usually. And if you see in retrospective series, smaller tumors are almost 90-92% G1 or G2. But in any case, even for small tumors, we always try to have a preoperative fine needle aspiration, where unfortunately it's not always possible to have a correct differentiation grade. And we know even that a larger tumor can hold in his inside different areas with different kind of differentiation. So it's not always easy. We try to do a multifactorial balancing of the risk of a higher malignancy.
Okay.
But the grading, the preoperative biopsy would be the only way of having that for certain.
And do you always do a PET scan before?
Yes, double.
Okay.
Gallium and fluorodeoxyglucosium.
Mm-hmm.
Dr. Isabella, how do you select out patient on clinical? What are the clinical and imaging criteria you select out patient for the parenchyma preserving pancreas surgery? How do you select your patient for various parenchyma preservation surgery?
Mainly based on the size and mainly based on the age, on how old are the patients. Because if they are very young patients, and they have a long life expectancy, I would consider more than a 74 years old patient that I should maybe perform a pancreatic tail resection, less complication, less risk of failure to rescue. I would go for a traditional resection for an older patient.
Do you also consider the tumor as functional or non-functional?
Sorry?
Functional status of the tumor, if it is non-functional, your approach will differ, or your approach will be the same.
I didn't understand.
If the tumor is functional and other tumor is non-functional, 2 centimeter or less. Functional versus non-functional neuroendocrine tumor. Like insulinoma or other tumor, insulinoma functional, insulinoma or some non-functional tumor.
If I do parenchyma sparing resection, even from functioning tumors.
What is your approach?
We can offer, we don't make the difference between the functioning and non-functioning.
Approach will be the same.
Yeah, we do the same.
Do you select, pancreatic duct stenting in all patients or selective for parenchyma, for enucleation? You shown PD stenting in patient with enucleation you perform. You did PD stenting, so that is all patient you do PD stenting or you do selective patient?
It depends. It depends on the closeness to the versum. So if it's really close,
it's selective then.
Yeah, we select them, not all.
I think there is no further question. Then we thanks Dr. Isabella.
Thank you very much.